Good evening, participants and delegates. Thank you for joining Shield Connect. And today we are going with the webinar Icons in Conversation with Dr. Ritu Santwani. And the today topics is port complication in laparoscopic surgery. And today our special icon speaker is Professor Dr. Mohammad Abdul Qayyum from Bangladesh. So before we start the webinar, let me give a quick introduction of our page also and as well as of our speakers. So this is our page shieldconnect.in. You can find various sections are available in this page. The first section is the blog section where you can find all the latest blogs related to COVID. So you can go there. Then we have a webinar section where we do webinars. So you can go through these webinars on various topics related to gynecology and obstetrician. Then this is the awareness pages. So if you click on any one awareness page, you will find all the details regarding to that topic. Then we have our key opinion leader page where you can find all the speakers who are connected with Shield Connect. And we have a special day pages. So if you click on any one of the day, you will get topics related to it. Like on hypertension day, you will click, then you will find all the topics related to hypertension. So this is our page Shield Connect. And now let me give introduction of our speaker, Dr. Ritu Santwani. Ma'am is director of Pune Test Tube Baby Center in Shamwell Women Clinic. And ma'am is also honorary professor of Women's Medical College, Gajrula. And to our icon speaker is Professor Dr. Mohammad Abdul Qayyum. Sir is done FCPS, is Professor Endoscopic Surgery in Parkview Medical College, Sylhet, and Chief Consultant Gynecological Endoscopic Surgeon in Feni Private Hospital and Laparoscopic Institute in Bangladesh. Sir is Vice President of Obstetrical and Gynecological Society of Bangladesh. Sir was appointed as Chief Consultant at Feni Private Hospital in June 2016. Sir has also been awarded as a Young Gynecologist at Asian and Oceanic Federation of Obstetric and Gynecology in 1998 in Malaysia. And Sir also presented on anatomy of gynecological laparoscopy in continuing medical program in SAFOG conference in 1998. Sir is founder member of Images, that is Indian Society of Minimal Accesses and Gynecological Endoscopic Urogynecological Surgery. Sir has attended other more than 20 national and international conferences. Sir has also conducted 13 workshops on basic laparoscopic operation and laparoscopic hysterectomy on non-distant vaginal hysterectomy in private hospital Feni in Bangladesh. And Sir is a national faculty in OGSB and conducted 7 workshops in OGSB hospitals in Bangladesh. So I welcome you everyone and I will hand over the session to Dr. Ritu. Thank you so much.
Yeah. Thank you, Dr. Nishant, and thank you, Shield Connect, for always being so cooperative. First of all, I want to have a warm welcome to all our delegates who have joined all across the geography, and very warm welcome to our today's guest, our dear friend, Dr. Mohammad Abdul Qayyum from the Bangladesh. So knowledge always increases by sharing, and knowledge is not limited to any boundaries. This is my motto for sharing the knowledge. With this motto, every week I am inviting one speaker from the from the country who is ready to share the knowledge with us. So today, Dr. Mohammad Abdul Qayyum is going to share with us what are the complications, port complications during laparoscopy. I think this is a very, very important topic. Especially for the budding gynecologist also who started, because in this era everybody is in the laparoscopy. Without laparoscopy, hysteroscopy, gynec practice is impossible. So today Dr. Qayyum is going to share with us. Post this session we are going to take some live questions. Over to you, Dr. Mohammad Qayyum. A very, very warm welcome. Dr. Qayyum?
Sir will reconnect. I think lost the connection.
Okay. So friends, we are every weekly on Thursday 8 to 9 p.m. The series are coming. So Those of you who want to have a discussion on some other interesting topics, please do post me the topics. You can inbox me. I will try to take that topics with the stalwarts. Next week, we are having with Dr. Ayman a very important topic, the PCOS, what's the recent advances in the treatment of PCOS. Again, on the 10th February, we are having Dr. Fauzia Chandio, who is a stalwart in the field of the urinary incontinence. She has done so many surgeries. So on the 10th February, we are having with our session with her. What are the recent modalities has been developed for the urinary incontinence? So like this, every week we are having some or the other series. Those of you want to have some special interest in some special topics, please do post me either in talks, or you can connect me on any of the social media, Facebook, LinkedIn, YouTube, or Instagram. And the program is going live on the YouTube. There are so many educative programs on YouTube channel, so you can see that on my YouTube channel also, and Shield's YouTube channel also. I think Dr. Qayyum has joined. Just a second. Let me check it. Sorry. I am calling him. I'm calling him. Just a second. I will just see. I think it's this.
Yes, ma'am.
So friends, meanwhile, Dr. Qayyum is joining. I think all of us are doing the basic laparoscopy. So what are the complications do you find while doing this laparoscopy procedures? So please drop your problems and what are the day-to-day practice you are getting the problems. So I can ask him post session. I'm just calling him.
Dear participants, you can post your queries in the comment section in Zoom. So during after these webinar session, we can have a Q&A session with sir.
Phone is ringing. I think he will be joined.
Yes, sir. Yes.
Yeah. So warm welcome, Dr. Qayyum.
Hello.
Hello. Yeah. Warm welcome. In our India, we say in Hindi, Namaste. A warm welcome to you. Yeah. So now the dais is all yours. First, you can take the presentation. Later on, we can take some live questions.
Okay.
Yeah.
Am I audible?
Yes.
Okay. Good evening, everybody from Bangladesh and from India and other countries. I am the laparoscopic surgeon, and I already introduced by the person. And presentation. My presentation is laparoscopic technique and its complication. It is my hospital in Bangladesh, and nowadays laparoscopy is modern operation done by the gynecologist. Every gynecologist can do this operation. And it is a many private hospital and laparoscopy institute. My hospital is equipped with latest technology, infrastructure,
Dr. Kaim, your voice is breaking. We are not able to hear you.
Now you are hello.
Yes, now it's clear. Now it's coming.
Okay.
Yeah.
Okay. And there is also facility for the laparoscopic workshop and training. So every gynecologist and laparoscopic surgery surgeon must know the laparoscopic anatomy.
No, again, we are not able to hear you. Dr. Kaim, we are not able to hear you.
Ma'am,
There is
Chitra here,
some.
ma'am.
Yeah, Chitra.
Okay. Now you are able to.
Yes, sir. Now we can hear you.
Yeah.
Okay. Oh.
Yes. Yes.
So that if you want introduction is that of the anterior abdominal wall, and this is the some structural landmark of the anterior abdominal wall. It is the umbilicus, anterior superior iliac spine, and pubic symphysis. The vessel of the anterior abdominal wall are the inferior epigastric vessel, superficial epigastric vessel, and superficial subcomplex iliac vessel. The layers of the anterior abdominal wall is rectus abdominis muscle, anterior and posterior rectus and arcuate line.
No, sorry to disturb you, Dr. Kaim. We are not able to hear you. Chitra, can you help? Or his
Sir, can you please remove your headset? I think so. That might be problem.
There is a issue with the headset, so.
Sir, can you hear us?
uh, Dr. Kaim, we are not able to hear you. Uh, Sorry to interrupt you, Dr. Kaim. We are not able to hear you. No. How to intimate him? Ask her. Huh? How to intimate?
Sir, can remove the headset and.
I'm calling him again.
Yes.
Now I think he is removed. Yeah. No, we are not able to hear you.
Now please change the setting into computer audio, sir.
Chitra is very good.
No, sir. You need to
No.
change the settings, sir. Now you need to change the setting as computer audio.
Can you see the mic button?
Sir, otherwise you can log out and log in again. That will help, sir.
Now you hear me?
Yes. Yes. Now we can hear you.
Okay.
Hello, now you hear.
Yes, sir. Now we can hear you clearly.
Okay. Hello.
Yes, sir. Yes, sir.
The anterior abdominal vessel.
Yes,
There
clear.
are the two superficial vessel. One is the superficial epigastric, another is the superficial circumflex. The bigger vessel is the inferior epigastric vessel. From the 8 centimeter from the midline, and the B is the vessel is the 3 centimeter from the pubic symphysis and 4 centimeter from the midline, and C is the inferior vessel 16 centimeter from the symphysis and 8 centimeter from the midline. Now you are audible. Hello.
Yes,
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 sir. Yes, sir.
yes.
The
Yes, sir.
laparoscopic surgery is currently being widely used. For the previous allow to perform the almost all surgery previously performed the laparotomy. So on the entering of the abdomen is the most dangerous part of the laparoscopic surgery. The complication rate can be expected to rise. So it is necessary to have a knowledge of the equipment, procedure, limitation, indication, and complication. The learning curve of the laparoscopic procedure is lengthy. Higher and technical utilization. Now, in minimal access surgery, if you see the technique of entering the inside the human body with port telescope instrument called the access technique, the incidence of laparoscopic complication in minor procedure is 1.1% to 5.2%. In major procedure, it is 2.5 to 6%. So if you see, most of the complications occur during laparoscopy. Of complication in abdominal access, we need supervised training program at all level of development and high degree of awareness of potential risks of complication. So the objective of my presentation to interrupt the data regarding the technique of laparoscopic abdominal technique and different techniques of primary trocar entry and discuss the placement of the axillary trocar. In the case of the laparoscopic surgery, the operative evolution. The evolution of the abdominal wall adiposity. That is in the case of the obese patient and in the case of the thin patient. So in the case of the laparoscopy, the planning of port is important and which place is the correct position for safe laparoscopic surgery. The technique of entering the abdominal cavity depend upon the types of the surgery and pathology of the surgery. There's the primary port position. Number one is the supraumbilical. It is 5 centimeter above the umbilical. Another is the intraumbilical. It is the 5 centimeter below the transumbilical. And another is the alternative port. It is the plasma primary port. It is the mid-clavicular line. So alternative site for insufflation of the port is the transpondal insufflation port. Another is the transpornic cell insufflation port. Despite of this method, no one method can claim the fundamentally superior to the other method.
Sir, sorry to interrupt you. Slides are not moving. It is still stuck on introduction slide.
Now,
Yes.
okay?
Yes,
Yes.
sir. Yes.
Yes, yes.
Oh, the abdominal access, it is the key of the success is the to success the port. There is the two types of the technique. One is the closed technique, another is the open technique. The closed technique, there is the one is the blind method, and blind method with carbon dioxide insufflation, it is the Barrett's technique method. Without carbon dioxide insufflation, it is the direct trocar entry. And another is the visual optical trocar insertion. It is one method. The open method.
Dr. Kayum, sorry, we are not able to hear you. Chitra, can I drop a message to join again?
Am I audible?
Yes, sir.
Yes.
No. In the case now, in the slide, one is the pediatric type, 8 centimeter, and the adult type is the 10 to 12 centimeter. And in the case of the bariatric patient, we generally use 20 centimeter. If you see the parts of the needle are stylet with eye tip and spring bulb. This instrument can be used for pneumoperitoneum in the case of the aspiration of the ovarian cyst or gallbladder to port closure, transfacial mesh fixation. But for the trocar and cannula for telescope is the two types. One is the reusable, another is the disposable. Whereas discuss the later on. The
Dear participant,
method
please
of,
mute yourself.
method of holding the Barrett's needle. Hold the Barrett's needle like a dart shape. Barrett's needle are two types. One is the disposable type, another is the reusable type. In the operation theater, preparation of the patient must do for successful of the operation. The bowel should be prepared and it done by the nothing for 24 hours with mild purgative, empty bladder by the Polish catheter, abdomen is examined by thigh, surgical scar, laxity of the abdominal wall, umbilical anatomy, abdominal procedure done by the Barrett's needle umbilically. The patient position is supine position, but during operation, it is 10 to 20 degree tendon bar position. The insertion technique. Insertion technique, abdomen should be examined for any palpable lump. Lift the lax abdomen maximally. Double skin thickness plus 4 centimeter to perforate the fascia and peritoneum. Varus needle should be perpendicular to the abdominal wall, but inserted at the 45-degree in obey towards the anus and 90-degree very obey towards the anus. Puncture of the posterior wall of the rectus sheath. Factor risks for Varus needle. If Varus needle is unduly long, and it may injure. Where if you do premature tunneling position due to the obligatory, there is risk for injury. Infovary insertion, and when there is a distension of the stomach, colon, bladder, and there is a sign of adhesion. In this, these are the risk factors for Varus needle insertion. And there is a obesity. In the case of the obesity, according to BMI of the patient, the overweight, it is 2.5 centimeter. In the case of the very obese, it is 2.9 centimeter. And in the case of the flat, in the supine position, trocar is safe and operation table is the fat. But position of the trocar and great vessel in the tunneling bar position is highly risky. Height of the incision is central of the umbilicus. It has the advantage. It is a hidden scar. The thinnest abdominal wall cosmetically better. No significant blood vessel. Ergonomically, it is better. But on the other hand, bacteria in the weakest part of the abdominal wall, so chance of the mental hernia. Other port site are the superior crease of the umbilicus in the case of the non-obese patient, supraumbilical or umbilical port site. We generally use gynecologists, most of the gynecologists use supraumbilical port. Indicator of safe interperitoneal placement of the Varus needle. If you heard the double click sound, we confirm I am okay. I enter the peritoneal cavity. Needle free movement. If the Varus needle move freely within the abdominal cavity, then it may confirm the Varus needle in the peritoneal cavity.
Dr. Qayyum, sorry, I'm getting lot of inbox messages. Voice is not coming clear. So if you permit, I think we can reschedule the program.
Yes, now you are audible.
Yeah, but in between the voice is going, I think net connection is poor.
Yeah. It is the net connection is poor due to the government control sometimes in because I am in the district level, sometimes otherwise technical problem. Sorry for your interruption. If the tip of the abdominal cavity, the irrigated water cannot suck out. If it is pre-peritoneal in the muscle, injected water can be spirited back. If irrigated fluid coming out, the surgeon should suspect the ascites, some cyst or perforation of the urinary bladder. If fecal matter is seen, then you must the bowel. If the blood is coming, Varus needle, the abdominal wall should be lifted up. And if the tip of the Varus needle inside the peritoneal cavity. Hanging drop should be sucked out inside the peritoneal cavity due to the negative pressure. Once it confirms the Barrett's needle inside the peritoneal cavity, tubing of the insufflator attached and flow is started. It is important to keep nice hold the Barrett's needle throughout while the gas is flowing. Otherwise, Barrett's needle can slip out, may create peritoneal insufflation. So, what is the most reliable safety test? The Barrett's needle interperitoneal pressure should be single digit. That is 2 to 5 seconds. It should not be more than 10 millimeter of the marker. It should be single digit. Yeah, this side. Umbilical area is the best. It is the cosmetic I already mentioned, but supraumbilical is also best in the non-obese patient. Unusual circumstances, alternative NT. When suspected there is a umbilical adhesion, umbilical hernia, 3 failed insufflator attempt at the umbilical. So alternative site is the upper quadrant, that is the palmar point. It is the 3 centimeter below the left costal border at the mid clavicular line. Another 2 is the transuterine through the uterine cavity and or transfornix through the posterior fornix, that is the posterior carnices. So palmar entry is indicated, I already mentioned the umbilical adhesion, hernia, etc. Surgery, no significant hepatosplenomegaly.
Very low voice.
Complication of Barrett's needle and pneumoperitoneum. Extraperitoneal gas insufflation, pneumoomentum, pneumothorax, mediastinal emphysema, gas embolism, blood vessel injury, injury to the gastrointestinal tract, bladder injury, puncture of the liver or spleen, complication of the distension media. So the extraperitoneal gas insufflation about the 2 to 3% cases. The recognition by the you can see by the telescope, and under skin we can identify the classification of the skin. So management can be done by the gas allows you to blood vessel injury. Why? But the Barrett's needle is small vessel, omental vessel and mesenteric vessel are injury. Major vessel are the abdominal or pelvic vessel. How you recognize blood is coming from the open needle and free blood in the peritoneal cavity or hematoma. So which patient are such injury? If there is adhesion, obese, thin patient or children. How you prevent? The inserting only as much as needle is necessary. You cannot give forcefully extra introduction of the Barrett's needle. And otherwise, lifting the abdominal wall, angling the needle towards the pelvis is also important. How you manage? The needle should be left in place, minimal bleeding controlled by the bipolar or severe bleeding, never vascular surgery. Gastrointestinal injury. Which case are predisposed for gastrointestinal injury? The upper abdomen at the side of the incision, insertion, intestinal distension, and adhesion of the bowel to the abdominal wall. How you recognize aspiration? Through the needle, GI tract fluid, belching, passage of flatus or fecal odor. How you manage? If there is no tear, broad spectrum antibiotics and observation. If tear is seen, it is surgically repaired by suturing. So there are the risk factors for the complication, prior surgery, intra-abdominal disease, endometriosis, PID, extensive bowel distension, very large pelvic abdominal muscle, extensive pelvic abdominal adhesion, cardiopulmonary of complication. Urinary bladder injury sometimes happen. It is usually simple prevention by the catheterization and proper seating of the needle, recognized by the pneumomaturia. Management by the conservatively post-operative catheter is sufficient for the healing. So another complication by the gas CO2, this is the carbon dioxide embolism, cardiac arrhythmia, and chest pain. Increased abdominal pressure plus anesthesia, decreased venous return, ultimately risks for deep venous thrombosis. So now I discuss the trocar insertion. Trocar could held in the palm like a pistol in hand. Index finger extend down to finger tip. Remove the fuser. Then, depending on the size of the trocar, you have to take it. Usually, safety trocar is mandatory. The tip of the trocar, there are the different type, the shield type, this is the pyramidal type, shield type, blade type, another is the conical type, radical expansible, and Hassan technique type, and another is the optical type. And these trocar can causing injury, and this injury is most serious. The trocar and cannula, there are the different size. 3 millimeter, 5 millimeter, 7 millimeter, 10 millimeter, 12 millimeter. Trocar with flap bulb is better than temperate bulb. Pyramidal tip is better than conical tip. Introduction of primary trocar after pneumoperitoneum of 20 to 20 millimeter pressure is better. Introduction of the secondary trocar always under primary trocar is good. Primary dose of paracetamol, but magnitude of injury is greater. So there are the some risk factor for injury. These are the due to the inadequate pneumoperitoneum, periumbilical adhesion, poor technique. So what is the adequate peritoneal pressure? That is the pneumoperitoneum. Adequate pneumoperitoneum should be determined by the pressure. We generally standard is the 20 to 25, it is the maximum. Abdominal pressure again be increased prior to insertion of first secondary trocar with a flat patient. A transient high peritoneal pressure in laparoscopic entry technique does not adversely affect cardiopulmonary function in LDO. Once insertion of the trocar is complete, this gives adequate distension for operative laparoscopy. Also allow the anesthesiologist to ventilate the patient safely and effectively. Laparoscope should be slowly introduced through the primary cannula. Then we rotate 360 degree to check visually for any adherent bowel adhesion, any other adhesion, or any evidence of the hemorrhage, damage, and rectoperitoneal hematoma due to the introduction of trocar or varicose. So, in the case of the suspected pneumo, bowel can be adhered to the umbilical. It can be seen by the primary trocar site by secondary or optical telescope. When there is a risk factor for the suspected umbilical adhesion, advocated for previous laparotomy, mini laparoscopy, and optical trocar can be used. Even open laparoscopy laparoscopy in a Hassan technique can be used. So risk factor or poor technique. Unusually long trocar can cause hazard. A premature tendon bar position in the case of the trocar introduction. Uncontrolled sudden entry. It also called the injury. Excessive force. A small umbilical incision. Scar tissue. Dull trocar. They suddenly introduced ultimately may cause injury. Improper angle. If you do not maintain the angulation of the trocar. So, the mark position causing the high liability of vascular disease. Because no doubt, ultimately, there will be pressure from near to the arterial signal valve. So, primary trocar should insert it a controlled manner at 90 degree at the skin, and insertion should be stopped immediately trocar inside the abdominal cavity. One useful technique is to gentle twisting the trocar while exerting palm down pressure. Excessive pressure to overcome the skin and facial resistance can lead to uncontrolled trocar entry, increasing the risk of injury to the bowel or other abdominal or rectoperitoneal structure. Now, the management of primary trocar injury. If there is injury trocar to left in this place, you should not do anything. Laparoscopy can be done to the laparoscopy or immediately laparoscopy. Or if there is a vascular injury, entry. After done in 1971, it involved the use of the modified trocar and very specific surgically made trocar. And it has very fewer unrecognized bowel complications, nullifies the risk of gas embolism or injury to the major vessel. You see, the risk of the bowel injury is only 1.1%. Risk of the post-operative infection is 0.4%. Risk of the vascular injury and gas embolism is 0%. So how you should do Hassan technique. A small incision at the skin of the umbilicus, then it should be deep in the fascia, then entering the peritoneal cavity in the direct B side. The cannula is inserted of the figure on the east side of the cannula. Illustrate there circulation is common. At the end of the procedure, facial defect and closed. How you should do secondary port. The secondary port must be inserted under direct vision, perpendicular to skin, with maintaining the peritoneum, pneumoperitoneum 20 mm mercury. During insertion of the secondary port, inferior epigastric vessel should be visualized laparoscopically to ensure that entry point is far away from the vessel. And this is the superficial epigastric artery, and this can be identified by the trans illumination of anterior abdominal wall. And if there is any injury, there should be subcutaneous hematoma and management by the teacher. How you should secondary port is inserted. You should insert once at the tip of the trocar has pierced the peritoneum, it should be angled towards the anterior pelvic under careful visualization and control upward and forward movement until sharp tip has been removed. After operation, secondary port should be removed. How you should remove? Secondary port must be removed under direct vision to ensure that any hemorrhage can be observed and treated if present. Injury biggest artery injury is happen. What you should do? That would be the bacteriolemia, hematoma, and removal of the primary troca. How you remove primary troca must be removed under direct visualization of the telescope to ensure that bowel is not entrapped. How there is a small intestine during the operation. If there is injury, you can recognize how the observation of the laceration area, observation of the intestinal content, introduction of the laparoscope inside the intestinal lumen. In the third or fourth day, post-operative fever, vomiting, and distension. Most common site of injury is the transverse column, and diagnosis by direct observation, delayed abdominal pain, distension, fever, passage of the fecal material of the abdominal fluid. Treatment, exploration, media, or cholesterol. Centimeter incision, each cannula is drawn with a valve closed. It is possible to draw a piece of omen trap into the umbilical wound by the negative pressure is so produced. So it should be recognized and immediately replace, and herniation may occur some hour after operation even. So it easily replaced under local anesthesia and resuture. Herniation does not occur commonly in 5 mm port, and any port greater than 7 mm should be sutured in layer to prevent formation of the richer hernia. So incisional hernia can be occur in some situations. There are some risk factors. These are the multiple ancillary or expiratory procedure are done during course port, increase of working time, use of port anchoring device, failure to close the fascial defect, prior history of herniation. So incidence of hernia in the case of the 5 mm port, it is 0.25%. In the case of the 10 mm, it is 0.5 to 2%. In the case of the 12, it is the 5 to 10%. In the case of the 15 mm port, it is 20%. So laparoscopic skill, how you should do skill? It requires long time. It requires 5 to 7 years to gain adequate laparoscopic skill by doing several procedures. Patient selection. Select appropriate patients for laparoscopy. Obstruction and to have umbilical vertical incision. So every time you should discuss with all patients in simple language, and we document the risks and benefit and alternative to laparoscopy or do laparotomy when needed. Operative difficulty. Consider conversion of laparotomy if difficulty are encountered or ablation of the procedure. If no harm has been done, surgery is elective. Report of the technical difficulty. In the operative record, discuss the complication of the post-operatively with the patient. Or patient complication. Consult the appropriate colleague. Maybe urology. access technique and port placement. All ports are at or below the umbilicus. Port position depend upon the history of pathology, nature of the operation, suturing technique, height of the surgeon, surgeon competence. An umbilical port is the primary port, 5 or 10 for telescope, lateral port, the accessory port, 5 or 3 mm for the working port. Between the two instruments, there should be the 60-degree angulation. Difficulty or extraperitoneal pneumoperitoneum, then palmar position. So wrong port position causes a stressful surgery. In conclusion, appropriate patient selection, early recognition of the complication, full disclosure to the patient is important. Minimize the physical, emotional, economical consequence of the hospital. Thank you for sharing. And thank you for the listening. Thank you.
Yeah. Thank you so much, Dr. Kayum, for such a brilliant lecture. Only thing, the net connection was poor, so sometimes the audibility is not good. But your slides are very crystal clear. Uh, I wish to invite you once again on my show, because today the voice is creating a lot of problem. Lot of doctors drop me a message. Your voice is not clear. Voice is not clear. But anyhow, your slides are very good, sir. A very crystal clear presentation. Thank you to all of. Thank you very much for enlightening all of us. And thank you, dear friends, also who all have joined.
Thank you.
Yeah. Thank you, She'll connect to Nishant. I think there are no questions.
Yes, ma'am. So
Yeah. I think we will invite Dr. Kayum once again,
Yeah.
because the presentation was very nice, but the net connection is so poor, so we are not able to hear in between.
no issue. We will reschedule it.
Yes. So with this, we are winding up for the today's session. So thank you, dear friends, and thank you once again, Dr. Kayum sir, for enlightening all of us.
Thank you, ma'am, Dr. Ritu, for inviting me. But I am extremely sorry for internet problem.
For why you are
No
sorry?
issue, sir.
That is a technical issue.
That is a technical problem. Yeah.
Okay.
And your hospital looks marvelous, Penny Hospital. I wish to see sometime your hospital.
Inshallah, you will come in future, inshallah.
Sure, sir. Thank you so much. Okay, friends. Bye-bye. Good night. Stay safe, stay healthy, and very important, stay connected. Bye-bye.